3. Hi, welcome to this ACNM approved continuing education session titled Endometrial and Skin Biopsy Techniques for Midwives. My name is Kristen Ostrem-Niemcewicz. I am a nurse midwife in New Mexico, and I'm joined by Shelly Collins. Shelly?
Hi, and I am also a nurse midwife, and currently I practice in Chicago, Illinois.
So this continuing education session is available and approved until July 7th, 2022. So these are our learning objectives. At the conclusion of this session, participants will be able to demonstrate skin biopsy, verbalize the indications for endometrial biopsy, discuss use of ultrasound and evaluation of the uterus and endometrium, and demonstrate correct technique of an endometrial biopsy. So in the next two video demonstrations, Michelle is going to be demonstrating the skin biopsy techniques.
Drawn up in a 1 cc syringe will be plenty, usually no more than 0.2 to 0.3 cc's of lidocaine will be necessary. And we want to use lidocaine 1 to 2% with epinephrine that keeps the bleeding down in the field. I want to also draw it up with a larger needle from the vial, but inject it with a needle that's small, like a 25 gauge needle, because that causes less discomfort to the patient. Remember the golden rule about injecting local anesthesia, not on the fingers, nose, penis, or toes. Anywhere that doesn't have good capillary supply, if we use epinephrine, we can shut down that circulation there and cause some tissue damage. And then I have my scalpel here to do this, and my pickups. And then I have 2 pairs of scissors just for showing you. I prefer the smaller ones, just in working in these small areas tend to be a little bit easier to maneuver. Next, I have my skin preparation, and you can either buy prepackaged betadine swabs or just pour some betadine into a medicine cup and use your 3 box swabs to clean the area, of course, starting at the lesion and going around in concentric circles. So I'm going to pretend I've cleaned the skin. I'm not going to do it on here because then it would obliterate the lesion I'm trying to show you that I'm biopsying. So next I'm going to inject, and we're going to do this intradermally, so it's just below the dermal layer, kind of holding the skin a little bit taut. And we're going to create a little bit of a bleb underneath the lesion, generally about a 3 millimeter bleb, so just the edges are a little bit wider than the lesion itself. And you will see it rise and often turn a little bit white where you've injected. Next, I'm going to take my scalpel, and again, holding that skin where the lesion is just a little bit taut, but away from the hand that is holding the scalpel for safety reasons. I'm going to make a very shallow biopsy incision, and with somewhat of a gentle sawing motion going back and forth underneath the lesion. And when I get to the very edge of what I'm biopsying, I'm going to use my pickups to pick up the specimen itself, and I can either use the scalpel to cut the very edges, finish the biopsy, or if it's easier to use my scissors, I might use the scissors to finish off the edges of the biopsy. And I'm going to place my specimen then in a cup of formalin and send to the pathology lab. You can see here it makes a very shallow incision. Usually there's very little bleeding, and most often a suture is not required. But if it was not hemostatic, you could put a suture in.
Thank you, Shelley. So this next video demonstrates punch biopsy of the skin.
In this video, we are again using the pig's foot, again, because it has the similar texture to human skin. And I've made a punch biopsy circle on the foot itself so that you can see to the left there of the pig's foot, you see the very round circular biopsy. And that's what the punch biopsy looks like once you've removed your sample. So I'm going to cleanse my site first, again, just like the other biopsy, with either betadine or alcohol. Most providers will use a betadine cleanse, and you can buy prepackaged or just use a cup of betadine with some box swabs. I'm not going to do the actual prep on this because it will be hard for you to then see the biopsy itself with the skin turning brown. And of course, I've obtained patient's consent and explained the procedure. Next, I have my local anesthesia. And again, 0.2 to 0.3 cc's will be adequate. I usually drop in a 1 cc syringe, 1 to 2% lidocaine with epinephrine. Again, epinephrine is good because it keeps the field free of blood. Golden rule, not on the fingers, nose, penis, or toes, anywhere that has a peripheral edge. This is my punch biopsy tool. They come in different millimeter widths. This is a 4 millimeter, which is one of the most common. You want your biopsy tool to be able to be larger than the lesion that you are biopsying. So the diameter needs to be larger. And then I have my pickups to pick up the actual specimen. And we'll need to pick that up once we've obtained the core biopsy, and then we're going to snip underneath to loosen it from the patient to be able to put it into the specimen cup. I've included 2 types of scissors here. I generally like to use the smaller ones, but if this is what you have in your office available, as long as they're slender and can fit underneath your core biopsy, punch biopsy, they would work just fine as well. And so I'm going to inject underneath the lesion. And as before, we're going to just inject just under the dermis at about a 45-degree angle there. And anywhere from 0.1 to 0.3 is usually adequate. It will create a little bit of a bleb underneath the lesion itself, and it will kind of blanch white. And you can test there with your pickups to see that the patient is numb. And I'm going to open my punch biopsy tool. These are single-use implements. You throw them once you've used them. And this is similar to drilling for oil. You're drilling a core, basically. So you make contact with the dermis, and once you just, with a gentle turning motion until you break the dermal barrier. And some sources will tell you to go down to the hub, and others will say halfway. I think it depends on what you're biopsying, how deep that you want to get and what area of the body you're in. It may be very shallow where you can't go to the hub of the punch biopsy implement. And when you have your core that has been created, you have to then use your pickups to pick up the sample because it's still connected to the patient by a stalk, if you will, and use your scissors to snip the stalk, holding the sample up, and then your sample is ready to go into the biopsy formalin bottle. And what you have left is a nice round area. Sometimes you may need to put a suture in this if it's a very wide punch biopsy tool that you're using, but most of the time a little silver nitrate or Moncell's could be used for any bleeding, and then just bandage in the usual fashion. And those are both just examples of what a punch biopsy looks like once it's done.
Great, thank you. And, this continuing education session is mostly technique based, but we know that you all would identify lesions that are suspicious before you choose to do the biopsy. So that's implied in those demonstrations. So Michelle is going to talk about dysfunctional uterine bleeding.
So there are many causes of dysfunctional uterine bleeding, and also there are many ways to refer to dysfunctional uterine bleeding. There have been other terms used for that, but for the purposes of this presentation, I'll use the term dysfunctional uterine bleeding. So first off, we can have anovulatory cycles that cause dysfunctional uterine bleeding. And especially from high steady state estrogen levels in the woman. So when you have this continuous estrogen stimulation, we get continuous development of the functionalis layer of the uterus until the estrogen feedback produces a slow drop in the FSH. Eventually, the blood supply is outgrown, and then we see parts of the endometrium begin to slough. Estrogen, however, promotes healing of that endometrial layer so that there are always some parts that are sloughing and some parts that are healing, resulting in this uneven, unequal bleeding kind of perpetually. Then luteal phase deficiency. A shortened luteal phase can be the result of insufficient progesterone production or insufficient effect of progesterone. The insufficient progesterone stimulation may exist along with either low, high, or normal estrogen levels, actually. And sometimes what you see here, this can be the result of anovulatory cycles. So sometimes when we see this, especially if there's a loss of the LH surge, this actually can be prominent in amenorrheic athletes, like with our athlete triad syndrome. Next, the declining number or quality of ovarian follicles, particularly for our patients who are over 40, they will have a diminishment of both their quality of their follicles and the number of them. The follicles do continue to develop, but they don't produce enough estrogen in response to the FSH triggering them. And so therefore, the estrogen continues to be produced. And what we see from that is a late cycle estrogen and breakthrough bleeding. Next, the improper balance of estrogen and progesterone. This may result in actually low estrogen levels from such things as low dose birth control pills. So what happens is when the birth control pills stimulate, the estrogen in the birth control pills stimulate the endometrium, there's really not a sufficient buildup of that endometrium to make it stable. And so we have this continuous kind of prolonged bleeding that never seems to go away. We can also see this by high progestin activity contraceptive pills. Sometimes patients on those type of pills might need a higher level of estrogen, or you might need to give them something with a lower activity of progestin in it. Sometimes this is a good example of this is the bleeding irregularities that we see with some of the implants, the implant like Nexplanon. And often with the mini pill, we see women who have this continual bleeding, and it's related back to this. The non-progestin containing IUDs may also cause some irregular bleeding and unpredictable bleeding like this as well for this very same reason. Endocrine disorders like hypoprolactinemia, which inhibits production and release of GnRH, can be a cause of dysfunctional uterine bleeding. PCO or PCOS, which produces anovulatory cycles, can be another cause. There are other metabolic disorders like Cushing's, both hyper and hypothyroidism, and premature ovarian failure that can result in dysfunctional uterine bleeding. And then also, postcoital bleeding can be a cause of dysfunctional uterine bleeding. And usually what this amounts to, or the number one cause of it, is a structural lesion of the cervix or the vagina, like a polyp. It also can be caused by infections like sexually transmitted infections, gonorrhea, chlamydia, or a friable cervix as a result of bacterial vaginosis or trichomoniasis. You can get polyps, both uterine or cervical. You can also, another cause of postcoital bleeding can be dysplasia of a malignant cervical lesion or even the vaginal epithelium, and that can result in this irregular postcoital bleeding. And then lastly, the submucosal myomas and endometrial polyps, adenomyosis, uterine fibroids, endometriosis, or pregnancy. And sometimes fibroids can come through. I've seen them come through the cervical opening, and you would not be thinking that this is a uterine fibroid because it's presenting outside the cervix, but it certainly can. So the risk of endometrial cancer, these are from latest statistics from the American Cancer Society, is about double that for white women as it is for Black women. We see it in most women in the decade of life of 50 to 60 years. 75% of the women who are diagnosed with endometrial cancer are postmenopausal, with a peak incidence in the late 60s and an average age at diagnosis of 60. A very small percentage can occur before the age of 40. So if you have a patient with symptoms or very suspicious for this, don't think that it only happens in women who are postmenopausal. It is a fairly common cancer of the female reproductive organs. It does have a survival rate of 96% if it's diagnosed and treated early, and that drops all the way down to 16% if it's diagnosed in a late stage. Some lab tests to consider if a patient comes in and has this dysfunctional bleeding pattern. And I won't say this is an absolute list because practitioners may have tests that they do or don't include on this list for a particular reason, but these are certainly ones that I would consider. First off, we can never, if a woman is of reproductive age, we can never rule out that she may be pregnant and having bleeding with pregnancy. So that's something to always think about. Even if your patient is not trying to get pregnant and she's past the age of what you might think would be, she would get pregnant. If she's still able to menstruate, of course, she can be pregnant. A CBC, because if she's had this dysfunctional bleeding, we want to know how it's affecting her as far as any anemia status. PT and PTT can be helpful in diagnosing a coagulopathy or leading you to a diagnosis of a coagulopathy, especially if you have this kind of bleeding in adolescence. And do know that adolescents, before they are ovulating, can have this dysfunctional bleeding, and that would be normal in a young woman who hasn't yet began ovulating. And then the Pap test, think about that if she's not current on that, because certainly, as I said on a former slide, cervical cancer needs to be on our differential list for somebody who's having this type of bleeding. The FSH, follicle stimulating hormone, can be done as part of a workup, and generally considered that a level over 40 IUs means ovarian failure. But I would caution you to know that this is not an absolute test, especially in a perimenopausal woman, because she can fluctuate and have over 40 and then go back to having less than 40 and actually produce follicles and get pregnant in the perimenopause. The highest, or the two age ranges where the highest numbers of unplanned pregnancies are in our teenagers and our perimenopausal women. So to note that just because you do one FSH doesn't, and it's over 40, you can't tell the woman that she's no longer able to get pregnant. Liver function tests can point us towards liver disease. A TSH can be very helpful in leading us to a diagnosis of whether the patient may be hyper or hypothyroid. A prolactin level can lead us to a pituitary adenoma diagnosis, particularly if the patient has breast discharge and she's not breastfeeding. We should be suspicious of an adenoma. And then insulin, glucose, testosterone, DHEAS are considered valuable in a workup for polycystic ovarian syndrome, or PCO. Some of the differential diagnoses then for abnormal uterine bleeding we've already talked through, but always be thinking of early pregnancy as one of your rule outs, and that the bleeding could be a complication of early pregnancy or even the beginnings of a spontaneous abortion. Leiomyoma, endometrial and cervical polyps we've talked about, and various genital cancers, genital tract cancers. Rarely we can see this dysfunctional bleeding as metastasis from bowel, bladder, and breast cancer. And in postmenopausal women, don't rule out that they may have atrophic vaginitis, especially if they are sexually active, that they may be having some friction there and causing some bleeding in the vaginal tract.
Thanks, Shelley. So now we're going to move on to the pelvic ultrasound, and I'm going to speak a little bit to the midwife performed ultrasound. So we all know that using ultrasound for clinical decision making is an expansion of midwifery practice. And I want to remind our listeners that we do have lots of resources on the ACNM website under professional resources, and there's a ultrasound education web page with information on education, certification, etc. So we know that when you expand your practice, you're going to be following standard 8 of the standards of practice, and you will include demonstration of competency and obtain credentialing in your facility. So I want to just say that what we're talking about in this presentation is really postmenopausal bleeding, and that ultrasound measurement of the endometrial thickness is not recommended for the premenopausal. And I just wanted to say that that's from the ACOG practice bulletin. If you have someone who's reproductive age, and we'll talk about that, over 40, then that would be an indication. But if it's a younger person, you're likely to catch the endometrial thickness that's somewhere in her cycle. So the American Institute of Ultrasound and Medicine has scanning parameters for the female ultrasound, pelvic ultrasound, and I just wanted to review that it includes measurement of the uterus and the adnexa, and I've underlined that the endometrium needs to be measured at the thickest area that's perpendicular to the longitudinal plane in the AP diameter, and we have some images to demonstrate that. I also want to mention that the ACOG 2015 clinical bulletin does mention that the evaluation of the postmenopausal dysfunctional or abnormal uterine bleeding does not require both a pelvic ultrasound and an EMB. Many of us in clinical practice will always order a pelvic ultrasound, or if you had the expansion of practice and you had the skills, you could do that pelvic ultrasound looking for those structural abnormalities that Shelley just mentioned in the previous differential diagnosis. So these are a couple of images that were gifted to us from Diana Dowdy, who is a nurse midwife and an RDMS sonographer. And as you can see that in this first image up here, we've got an abnormal endometrial lining. It's 5.1 millimeters. So the initial centimeters was, it's 5.1 millimeters if it's 0.51 centimeters. And this would indicate need for an endometrial biopsy. The endometrial image here has a 2 millimeter or normal endometrial thickness. So we know that an endometrial thickness of less than 4 millimeters, and in the ACNM clinical bulletin that we're going to talk about in a little bit, they refer to 4 to 5 millimeters, but it's generally considered that if you're 4 millimeters or less, that is normal. If you're 5 or greater, that is abnormal and an indication for an evaluation. So transvaginal ultrasound is usually the imaging of choice when you're evaluating abnormal uterine bleeding or dysfunctional uterine bleeding. This was an image from Diana Dowdy, who sent it to us because it's a nice demonstration of a very abnormal endometrial thickness. So this is a transabdominal ultrasound. You can see the bladder here, and it's really important if you were to look at the uterus that you have a full bladder so that you clearly can identify the myometrium and the endometrium. And this is very abnormal. As you can see, it's 2.78 centimeters thickness. And you would definitely be referring this patient. You could do an endometrial biopsy while you're waiting for referral, but this is grossly thickened. And this is just a reminder that if you had someone who's premenopausal, that it would never be normal if it's greater than 16 millimeters. So the fact that this is 2.78 centimeters is very concerning. So just to repeat, an abnormally thickened endometrium, which is 5 millimeters or greater, or an incompletely visualized endometrium is a referral for either a sonohysterography, which is what AIUM recommends, or a hysteroscopy, which is what the ACNM document recommends. And we'll talk more about this, but if you have an insufficient endometrial sample, it definitely does not rule out cancer.
So some causes of endometrial cancer, well, the exact cause may not be known. I've mentioned some risk factors earlier on. One is definitely unopposed estrogen administration. When Premarin first came out, or was the first, endometrial cancer is not known or not able to be found, but there are some things that make a person more at risk. One is unopposed estrogen administration. When Premarin, which was the first available product for menopausal symptom relief, came out, and women took it unopposed, meaning that they had an intact uterus and they just took the estrogen product with no opposing progestin product, then their estrogen levels, circulating estrogen levels, were too high and overstimulated that endometrium and then built up the endometrium to abnormal levels. And they actually presented with, at the time that those products came out, shortly after that, when many women were taking them, we saw a rise in the incidence of endometrial cancer. It is directly related to the dose and duration, and it does decrease with, or the risk decreases once the patient stops taking the unopposed estrogen. So now we know that if a woman has an intact uterus, she must take progestin along with the estrogen so that when the lining is built up, that the lining is then shed as a result of having the progestin stimulation. There are some metabolic illnesses that increase a woman's risk, particularly diabetes, PCO, and obesity. We do know that a certain amount of estrogen is metabolized in fat. And if a woman has more adipose tissue, then of course she may have higher circulating levels of estrogen. And it sort of leads to the situation I just talked about, where you have this sort of not unopposed estrogen administration because she's producing her own progestin, but the amount of estrogen is much higher than the amount of progestin that she may be producing to counteract the estrogen. Tamoxifen use. Tamoxifen is used to prevent recurrences of breast cancer in women who've had breast cancer. And I'll mention that in another slide, but just on this to say that in the trials on it, that the incidence of development of endometrial cancer was about double that for those women on tamoxifen versus those who were taking a placebo. And then past history, family histories of ovarian, colon, breast cancer can see a higher incidence of endometrial cancer as well. And of course, families who've had an incidence of endometrial cancer in first-degree relatives, mothers, sisters. And infertility and nulliparity do play a role in this as well, particularly in that the unopposed, often the unopposed estrogen stimulation of their endometrial lining that leads to the situations that result in infertility and nulliparity. So indications for an endometrial biopsy: greater than 45 years of age with abnormal uterine bleeding, and women under age 40 with abnormal uterine bleeding and a risk factor like chronic anovulation, obesity, tamoxifen use, diabetes, family history of any of the things that I mentioned. Failure to respond to medical treatment of abnormal uterine bleeding if you've tried some avenues to treat the bleeding and it continues, and women with a uterus in situ receiving unopposed estrogen replacement therapy. So in women younger than 45, an endometrial biopsy is only indicated if abnormal uterine bleeding, if an abnormal uterus is present. Oh, wait, you know what? Let me do this one again because I don't know what I meant there.
Okay.
In a woman younger than 45, is only indicated if abnormal uterine, oh, bleeding is persistent. Okay, all right. Indications for an endometrial biopsy include women over 45 years of age with abnormal uterine bleeding, if they are under age 40 with abnormal uterine bleeding, and an accompanying risk factor or factors like chronic anovulation or obesity, tamoxifen use, diabetes, or family history of the things I mentioned on the previous slide. If they fail to respond to any medical treatment that you've tried to correct the abnormal uterine bleeding, and women who have a uterus in situ who receive unopposed estrogen replacement therapy. So in women younger than 45, an endometrial biopsy is only indicated if the abnormal uterine bleeding is persistent. Endometrial biopsy should also be considered if, as I said, if there's a history of unopposed estrogen exposure, failed medical treatment, or at women at high risk of endometrial cancer. In women over the age of 45, any abnormal uterine bleeding should include an endometrial biopsy in the diagnostic workup, whether that's just some spotting that she has or like a heavy bleed. There's another special subset of pre- and postmenopausal women in whom ACOG provides specific guidance in their recommendations for endometrial biopsy. And these are the women I've mentioned who are on tamoxifen therapy. For all postmenopausal patients on tamoxifen therapy who have abnormal uterine bleeding, an endometrial biopsy should absolutely be performed. For premenopausal women on tamoxifen therapy, it's common to experience menstrual irregularities while on the tamoxifen. Most commonly, they will be amenorrheic while they're taking tamoxifen, but sometimes they may have this dysfunctional bleeding. So the guidelines do not suggest routine endometrial biopsy in this subset of women, unless there are risk factors for endometrial cancer in these premenopausal women treated with tamoxifen. They don't require any additional screening or workup beyond routine gynecologic care. Some other indications are the presence of atypical glandular cells on cervical cytology, and you will follow, of course, your ASCCP guidelines as far as when an endometrial biopsy is included as part of the workup accompanying an abnormal Pap result. Presence of endometrial cells on cervical cytology in a woman 40 years of age that don't correlate with her being on her menses at the time that the Pap was collected. And this will be a clinical, this will be putting the whole clinical picture together of what was going on at the time that the Pap was collected. Oftentimes it's maybe a few days after her menses had ended, and that would be completely normal to have had endometrial cells on the Pap result. Women who have hereditary non-polyposis colorectal cancer, their family then carries this genetic mutation that inhibits DNA repair, and they are more at risk for developing cancer. I put a question mark by evaluate infertility because this endometrial biopsies used to be done to evaluate the endometrium, but they are very rarely used any longer in the evaluation for infertility. But I put it here for basically historical sake and in case you may see that done in practice. And then follow up again on endometrial cells on the Pap. Some contraindications, both absolute and relative. Pregnancy is absolutely a contraindication to doing endometrial biopsy. You would disrupt the pregnancy to insert the pipelle into the uterus. If a woman has cervicitis or endometritis present, that can be treated, and then the endometrial biopsy done at the conclusion of the antibiotics, the patient's antibiotic course. If they have acute pelvic inflammatory infection, it would not be wise to do an endometrial biopsy at that time. She could be treated, and then the biopsy completed. It would only put it off for a matter of days, so it'd be more prudent to do it when she's has completed her treatment. Any acute cervical or vaginal infections, for the same reason as we would not do it with endometritis, cervicitis, or pelvic inflammatory infection. And cervical cancer, we would want to address that first prior to doing the endometrial biopsy. Of course, if a person, for example, has atypical glandular cells on their pap and they're over 35, then the endometrial biopsy would be part of the workup for the cancer. So this would be part of a clinical picture and putting all the pieces together.
So this is just kind of a support for the endometrial biopsy as being the method of choice for evaluating the endometrium. Both the Society of Radiologists, they came out with a statement in 2001, and that's been supported since, that endometrial biopsy or transvaginal ultrasound are effective as the first diagnostic step in the evaluation of the postmenopausal bleeding. And ACOG's 2015 clinical bulletin that outpatient endometrial sampling with a disposable device is reliable and accurate for detection of disease in most cases of endometrial cancer and has become the method of choice for evaluation.
Some conditions that may prohibit the endometrial biopsy, not that they are contraindicated, but that may actually prohibit you from being able to get a sample. One is morbid obesity, just because it may not be feasible to be able to get to the cervix and then pass the pipelle if the patient is very morbidly obese. If the patient has severe cervical stenosis, if it's impossible to pass the pipelle through the cervix, you can't get to the endometrium. I have used Cytotec to soften the cervix prior to the day before to the patient coming, and sometimes that has led to success in being able to pass the pipelle. And then some coagulation disorders, which may precipitate a large amount of bleeding and blood dyscrasias, then perhaps that should be done in an inpatient setting rather than an outpatient setting in case you have inordinate bleeding.
Shelley, I also wanted to add that I think that morbid obesity might be also a patient that could be evaluated in the inpatient setting by one of our physician colleagues in the operating room, right?
Yes, absolutely.
So we wanted to make sure that you all knew about the clinical bulletin that ACNM published in 2017 on endometrial biopsy. So that's nice that our professional organization has a document to help you with your expansion of practice. And we're going to be referencing this document on the next slide. It has the procedural steps if you need to produce a clinical practice guideline for your credentialing or any kind of privileging, then this would be helpful as well, just knowing that it's been published. And I wanted to say also with the document from ACNM, it does talk about different devices and how well they will retrieve a sample. It recommends using the pipelle, and in our demonstration video, Michelle is using a pipelle device.
So in preparation for the biopsy, you're going to, of course, discuss the risks and benefits with the patient. There's very little minimal preparation on your part. The main thing is making sure she understands risks and benefits and obtaining informed consent. You do need a negative pregnancy test if they are of reproductive age, even if they haven't had a period for months and they're in that perimenopausal stage. You still need a negative pregnancy test result before proceeding. It's prudent to have the patient take an NSAID like ibuprofen 30 to 60 minutes prior. As I tell students, this is probably the most uncomfortable procedure that we do on an outpatient basis, even though it takes literally seconds to minutes to do. It's very uncomfortable while you're doing it, and so this can help with the cramping that she feels. And there is no antibiotic prophylaxis necessary prior to doing this. It's similar to an IUD insertion in that way, in that you don't need an antibiotic prior. Patients again should be told about the risks and benefits. And also there is no prophylactic antibiotic necessary for patients who have history of bacterial endocarditis. Complications, uterine perforation. You can see the risk there is very small. The complication, stenotic os, actually is more of a barrier to actually getting to obtain the sample rather than a complication, but there are some sources that list a stenotic os after a procedure like this, which would be very, very small. Oops, sorry, my phone rang. Okay, I'll start again. So complications, as you can see, the risk of uterine perforation is very small. Stenotic os, really that's more of a barrier of getting the sample done. However, there are some sources that say that it may cause some stenosis just trying to pass a catheter through or a pipelle through the cervix itself. Of course, cramping, again, it's very uncomfortable to do. You can produce an infection from doing this procedure. And what I've probably seen most commonly is a vasovagal response. Patients are very nervous. They come in without having eaten. They sit in your waiting room and wait, and they're just all the entire time worrying, of course, very understandably. And then they get on the table and they faint either while you're doing the procedure or after. Once the procedure is completed, women may report light vaginal bleeding or spotting for several days. And that is completely normal, and they should be told that. They also should be monitored or should be instructed as to when they should call your office back for results, or when you will be calling them for results, that they may have some cramping. But if that cramping continues for more than 48 hours, if they develop a fever greater than 100.4, if they have increasing pain after they leave, if they're bleeding heavier than a normal menstrual period, or if they have any foul smelling discharge, they need to let you know about that. But again, the discomfort really is while it's happening, and then once you finish, it's greatly diminished. So the procedure itself, you're going to do a bimanual exam to check for the size and shape of the uterus. And then you can use a benzocaine spray cervically, or you can do a paracervical block. However, quite honestly, the discomfort is not in passing the pipelle. It is once you are inside the uterus, and there's no way to numb the inside of the uterus. So while you can topically numb the cervix or do a paracervical block that will numb the cervix, really where the discomfort's coming from will not really be affected by either of those things. You're going to cleanse the cervix with betadine, and then stabilize the cervix with your tenaculum, just as if you were going to insert an IUD. You're going to sound the uterus next, and the endometrial pipelle may be used to sound the uterus. It does have measurements on the side of it, or you may sound with another implement, just a regular sound. You're going to insert the catheter tip to the fundus where you feel resistance, and then you're going to withdraw the internal piston, and that is what creates the suction. You don't want to pull the piston out before you put the pipelle in, because then you won't have suction once you get in there. And this is the important part. You must twirl the pipelle between your thumb and your fingers while you are going in and out. So there are two motions going on. You're twirling in a 360-degree motion, the pipelle, and you're passing back and forth from the fundus to the fundus and back to collect your sample. And here I will demonstrate for you and
Sorry. Okay.
And here I will demonstrate for you what I just talked through. So I like to use liver to practice this because it gives you a return in your endometrial pipelle similar to what we might get from an actual person. So you can just buy a piece of calf's liver and wrap it up in saran wrap to practice with. I don't have a specimen bottle here because I wanted to show you what the specimen looks like swirling around in water, because it looks somewhat like a little snake when you expel it from the catheter. Then I have my implements here in front of me that I will need for the actual biopsy. I have my sound I've put two sounds out here. I have a metal sound and a plastic sound. And then I also have a little bit off camera there, what I'm going to wash off the cervix with. And that's a betadine solution, either prepackaged betadine swabs or just some betadine in a cup using my box swabs. And then I have my tenaculum here, which I'm going to use to grasp the cervix. And again, my metal sound. And if you're going to use this, the way that you properly use it is to take a box swab. You're going to insert the sound to the fundus of the uterus. You put the box swab at the cervix itself. You pull both things out together, and then you hold them up next to your pipelle, and that's how you can tell the depth of it, or the measurement of it. There are measurements on the sound itself, but I find they're very difficult to read on a metal sound. Also can use most people like to use these disposable sounds, which have the numbers alongside them. And the nice thing about them is when you paint the cervix with betadine, once you put the pipelle in, it often marks the sound for you. Okay. Then I have my pipelle, and then I have scissors, which I'm going to need. Before we put the sample in the formalin, I'm going to cut the very tip off of the catheter and then push with the piston, push the sample down through the catheter into the formalin. So I've washed off the cervix, and then I've grasped my cervix with the tenaculum. And here, again, don't pull out the piston ahead of time. You want to wait till the endometrial pipelle is in and inserted, and then you're going to pull out the piston. Now, here I'm also talking about the motion that I was referring to. You must roll between your finger and your thumb, the pipelle, and you must pass back and forth to the fundus and back. So you have two motions going on simultaneously, rolling and passing. And you must do these things together to accomplish a sufficient sample. So I'm passing through the cervical os. I know the depth of my uterus. I'm pulling out the piston, and you can see I'm rolling and I'm passing back and forth. And there is a large return in this catheter. I'm going to cut the very tip off of the off of the catheter. And this we don't include in the sample. So we just cut the very tip off. And this is to prevent damaging of the tissue sampling that we have passing through the catheter as we expel it. And when you expel the contents into your formalin, it comes out sort of looking like a little snake. And tap, tap, do what you can to get every last bit of that sample out of your catheter. And that concludes the endometrial biopsy procedure.
So one of the reasons we wanted to make this continuing education is that you could practice doing these procedures at home, just as Michelle has shown you by purchasing either a pig's foot or the liver, and then bringing the equipment or doing it as a group practice and using this continuing education as kind of a support for that clinical practice or that simulated practice. So this is an algorithm that talks about managing the results of your endometrial biopsy. And it is originally adapted from Brand and Boardman. And there's a couple of things that we wanted to add to it. So obviously, if you have a normal endometrial biopsy, but your bleeding persists, you still need to work up this woman. So just a normal endometrial biopsy is not going to reassure you if you continue to have the abnormal bleeding, and particularly if she is high risk for cancer. So you can see there are different options: repeating the endometrial biopsy. If a transvaginal ultrasound has not already been done, adding that on for additional information, and then following down the algorithm. If you still have normal results and your bleeding persists, you need to consult. You never want to stop if you have abnormal bleeding. And so this, the other part of this algorithm talks about if you get your ultrasound results and the endometrial lining is greater than 4 millimeters, then obviously you'll consult. And that's exactly what we were saying earlier. So there is a nice article by Goldstein and Anderson that's in the reference page, and they do a review of the endometrial biopsy literature, and they kind of criticize a negative blind endometrial biopsy as being not enough if the person consistently or persists to have abnormal bleeding. And so they talk a lot about the surface area in the studies where they've shown a high retrieval rate for endometrial cancer. It's with a greater than 50% of the surface being affected by cancer. But if it's less than 50% of the surface, you could theoretically have a normal endometrial biopsy, but you still have cancer present. So that's kind of supporting that continued follow-up that you see in this algorithm. This is the study by Atz et al. That's also in the reference page, and it just further supports kind of the workup. So out of this about 550 women, 74% of the endometrial biopsies had a sufficient sample and 25% had an insufficient sample. So I wanted Michelle to talk about, you know, how often did she see insufficient samples in her results, and what could cause an insufficient sample?
So I think of insufficient sample in two ways. The laboratory could say it's an insufficient sample because there wasn't enough tissue to look at, or we could consider it from a more holistic step back and take a more holistic definition of insufficient sampling, meaning that probably provider error or poor provider technique in obtaining sufficient sampling. So in the first occasion I mentioned, the lab, I guess, would simply send you a message that your sample was not adequate enough, in the same way that you get a pap test back that says there's not enough sample there for the pathologist to adequately judge the pap. In the second, sometimes we will never know about that, because if there is poor technique and we don't get insufficient sampling, but there is a cancer present, we may not find out about that until later on, and the diagnosis may be delayed, and of course prognosis may be poorer for the patient.
Right. So as you can see in this, the results of this trial of this small number of women, what we wanted to point out was with an insufficient sample, you still want to move on to the workup. In this group, this clinical group, they did some repeat sampling, some went off for hysteroscopy, hysterectomy, second transvaginal ultrasound. But we wanted to point out that 16%, if you look all the way down on the repeat sample, 16% of that 25 women, that the group of 25 women had endometrial carcinoma. So the take-home message is that if you have persistent abnormal bleeding and a normal endometrial biopsy, you still want to move on to consult and do the workup. If you have an insufficient sample, you might want to consult to find out what is the next step. If you don't have a transvaginal pelvic ultrasound, you might want to obtain that to kind of further augment your consultation with your physician partners. And last, we wanted to let you know about a publicly available endometrial biopsy procedure competency tool. And we know that part of our standards of practice for nurse midwifery in Standard 8 requires us to not only learn about a procedure, but then to demonstrate competency and to do quality assurance on our own technique. So these CPT codes are correct. I double checked them. They were current as of 2019. And this is a link. If you just Google the EMB procedure competency tool, it's a nice tool for you to use in your expansion of practice packet. So these are our references, and we want to thank you so much for your attention. We hope that you are going to go out and purchase a pig's foot and some liver and practice these different techniques as you move forward in your expansion of practice and offering services to your clients. Thank you.